So this is actually my first serenation case that I did. This was a patient who came to us that had a significant amount of hindfoot disease, multiple areas of ulcerations, and very adequate inflow. There really wasn't any problems with the femoral popliteal segment whatsoever, but was having a really difficult time addressing this hindfoot. I should probably also remark this was a couple of years ago, so really it was before we were doing, I guess, if you will, like advanced tibial work, the pedal loops, DVA, stuff like that. And it was, tibial was, I guess, in a lot of regards, kind of this great unknown. What happens to the vessels after you balloon them? What happens if you get a flow limiting dissection? So I very much was looking at cases like this with a lot of trepidation. But as you can see, there was diffuse tibial disease here. Both the tibial perineal trunk and the proximal posterior tibial vessels were heavily diseased. And I believe we did IVUS with this, and we elected to treat. We did 2.5 for the proximal posterior tibial and 3.0 by 40 for the tibial perineal trunk. And I hope you can see my results slides. But this was after our prolonged inflation, and we had an excellent result going down to the hindfoot. And actually, I think with that, we kind of left it. We said, all right, that's enough. I felt like, well, I was dancing a little bit with the devil with doing 2 balloon inflations inside the tibial vessels. But now that I've gotten obviously more comfortable with the tech, I wouldn't have left behind that perineal lesion. But such was the case. It was going nice and easy early on.
The post tib and the TP trunk look great.
Yeah, amazing. No flow limiting dissection. I mean, it looks like it looks like the adjacent vessel, perfectly. So it was really, I was very impressed with the technology. And then we were off and running after this.